Hello, my name is Shellayah, and this summer I worked along Chief Thoracic Surgeon Charles Mulligan and medical oncologist Michael Garino researching surgically resectable esophageal cancer at the Helen Graham Cancer Institute between the years 2002 and 2017. Esophageal cancer is when there's a cancerous tumor of the esophagus, and it can take part in any of the anatomical thirds of the esophagus along with the gastroesophageal junction, and this is where the stomach and the esophagus meet. Over the past decade, surgical approaches have gone from invasive, which are open procedures, to minimally-invasive procedures, which are the closed ones that are camera-guided. Our objective is to review and analyze the surgical outcomes of esophageal cancer patients at Christiana Care with national averages. We used resected esophageal cancer patients treated at Christiana Care between the years 2002 and 2017, and reviewed patient health information such as their demographics, comorbid diseases, smoking and alcohol history, treatment order, procedure information, tumor histopathology, surgical morbidities, and their survival rate. 699 patients were treated at Christiana Care between the years 2002 and 2017 for esophageal cancer. 173 of these patients were resected. 15 of these patients were resected at other area hospitals, leaving 158 patients for our analysis. Of our patient population, 84% were male, 94% were Caucasian. Our highest age quartile was between the ages of 65 to 74 with 33%. Our average age was 63 years old. 80% of our patient population had tobacco use or exposure, smoking at about a pack per day. 70% of our patient population had alcohol usage, drinking about 2 drinks per week. 33% of our patients had gastroesophageal reflux disease, and 35% of our patients had a lower esophagus tissue abnormality, also known as Barrett's esophagus. The current curative treatment order for esophageal cancer consists of chemotherapy, radiation, and surgery. 31% of our patients had adjuvant pre-op therapy. 20% of our patients had neoadjuvant, adjuvant post-op therapy, and 39% had surgery alone. 48% of our patients had the invasive open Ivor-Lewis esophageal gastrectomy. 17% of our patients had the minimally invasive Ivor-Lewis esophageal gastrectomy. 39% of our patients had other approaches such as transabdominal, intra-abdominal, laparoscopic, and through thoracotomy. This is a Kaplan-Meier survival approach showing that our median survival was 26 months for our resected patients. 73 of our patients had post-op complications. 11% had an ischemic leak, which is esophageal leak, and 11% had an ischemic stricture, which is esophageal thickening of lining. 9 of our patients died within 30 days of operation, and this 30-day gap is usually surgically related, and we went down from 6% to 0%. Limitations to our study is that not all esophageal cancer patients can be resected. Some considerations are patient health, cancer stage, and tumor location. We had a small patient population, and 15 of our patients were resected at other hospitals. To conclude, we've noticed with the transition from invasive to minimally-invasive procedures a decrease in both operative mortality and morbidity. Our median survival was stable at 26 months, and our 5-year survival increased from 32% to 38%. As you can see, compared to national averages, Christiana Care, in terms of operative morbidity, mortality, and 5-year survival, is close with national standards. And I'd like to thank Dr. Mulligan and the thoracic team at the Helen Graham Center, Dr. Michael Garino, and all Christiana Care employees associated with our work.
Any questions? Okay, thank you.
Thank you.
Hi, my name is Sydney Schuster. I'm a student at the University of Delaware, and my mentor is Dr. Adam Raven. Our project is evaluating